Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athlete trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. This education episode is actually going to be the first one of 2024. Yes. Yes, that was a good horn.
I feel like it just has to happen.
It has to, for sure. And we will be talking about something that I'm pretty sure in every pathologies episode that we've had has come up as part of the return to play process, and that is functional testing.
And something that we don't leave you here on AT Corner wondering is, what do I do now? That's why we're doing this episode.
Yeah, that is very true. We're all about action.
Oh, we better remember that at the end. Do an action item.
We always talk about doing it, and then we do the episode, and we're like, okay, cool. Yep.
So this is a CEU episode. Please scroll down to the show notes to see what the latest update on the CEUs are. We are changing some things for 2024. So if you are listening to this as it comes out, it is a free CEU. So make sure you scroll down to the show notes to get more details on how you can get that. What are we talking about today, Randy?
So we are going to be talking about functional testing. In particular, we're going to describe what is functional testing, so you kind of have a nice idea of what that means. We'll examine the effectiveness of functional testing during the return to play process, right? I mean, that's what it's been advocated for, so let's see how effective it is. And then we'll talk about examining the effectiveness of functional testing and actually injury risk screening.
Mm-hmm.
Yeah. So
let's get us started. What actually is functional testing?
So some people might know this, or even like if you were to look in the literature for this, right, you'll probably come across the term performance test. So they're kind of used interchangeably. So basically what's happening is you're doing an assessment in which the patient performs a physical activity that is considered a component of their sport. So most of the time when people think of this, it's kind of like the hop testing, like single leg hops, right? You have to be single leg. It's a power activity, right? So that's kind of the physical activity that is a part of sport, right? That's the idea behind it. And often this functional testing or performance test are used to in return to play decisions, right? That's probably what I'd say most common for clinicians to use them. But also there's some stuff out there on looking at, can it help identify someone that might be at risk of injury?
Interesting. I guess I always thought of functional tests used as kind of a return to play.
Yes, right?
And more, I guess you can use them as a screen. There are such thing as screens.
Yes.
When I worked in performing arts, we did have screens that we would have. It was basically functional testing.
Yeah, for sure.
And it was a series of squats and planks and kind of like lunges and different functional tests that we would assess their movement and we would grade them in certain aspects.
Yeah. And
we would use that as a injury risk assessment.
Yeah, for sure. And that kind of goes along the lines of like the different areas that these tests are trying to identify in athletic performance. So like those kind of tests, right? Looking at movement quality, how can you do it? Other tests look at like strength, power, endurance, and agility. All right, but for most of the tests that you commonly see for that return to play process, they're really only looking at like strength and power, right? When you think of like the hop tests, right? That's more of a power activity, right?
Mm-hmm.
And a lot of times it's not just one test that people are doing, right? They're kind of doing multiple, like you said in your screen, right? There's probably different movements that they're doing as a part of the entire screen.
Mm-hmm.
All right. In general, like, again, with the hop test as an example, usually people are performing about 3 to 4, and you're kind of grading each one based on their distance, right?
Mm-hmm.
So that does tie into the scoring, and it really kind of depends on the test that you're using. For a lot of those tests that look at the extremities, so for the legs, right, those hop tests, they're really going to be comparing both limbs to each other, right? The idea behind that is, the uninjured limb should theoretically be somewhat normal. That should be, quote unquote, your baseline, which we'll kind of talk about that. And then the injured limb is the one that we're trying to get caught up to the non-injured limb.
I mean, you also have to think about dominance and non-dominant side.
That could play a role as well, 100%. There's even been some question about that. Because a lot of time when you at least think of lower extremity, the dominant leg, a lot of people usually say, oh, which leg would you kick a ball? But there has been the argument made, the more quote unquote dominant limb is the opposite
It's a standing leg.
because that's the one you're landing on to swing your leg through.
That's what I use as the dominant leg.
You would have a good basis to say that that's correct, for sure. So for those tests that kind of look at the extremities, right, looking at an involved limb and a not involved limb, they're going to grade the asymmetry based on the limb symmetry index. So basically, it's just an equation where the injured limb, like the results of that, like however far you jumped, is divided by the uninvolved limb, how far that limb jumped, and then multiply by 100 to get a percentage. Right? So you're basically trying to look at how much are they different, right? So 100% would be they're perfect. They're equally the same.
I feel like that seems easy enough.
Yeah, right? Not too bad.
We don't have to do any algebra.
Exactly. It's just simple
basic,
arithmetic.
Yeah.
And we like that. You could even program that into an Excel sheet. You don't even have to do the math.
I never thought about that. You just changed my functional test. We've been doing it by hand. Wow, I think that's something that...
Man, look at that. Instant results. We haven't even finished this episode. And then there are also some tests that use basically a threshold, right? Whether it's looking at like a certain time or a certain amount of reps, right? If you go over this amount of reps, you're in the clear. If you do not achieve this amount of reps, that might be a problem.
Those, I've seen reps as normative of age and some other factors.
Mm-hmm.
When you were looking into the data, did you see that reps were typically by age?
Well, a lot of the stuff I looked at too,
or by sport, or by...
A lot of the stuff that I looked at was one in more of college age because it was more geared towards student athletes. As with a lot of this kind of research it's a lot of times geared towards college students or college aged.
Oh, that's actually kind of interesting.
Yeah, because like when they're looking at physical activity stuff, right, what's the easiest way to recruit? College students. Yeah. Right, they're not doing anything. Right, so that's where a lot of the stuff does come from. So that is a limitation. Like, okay, you're 40-year-old industrial athlete, right? Are we expecting them to do the same? So I didn't see that out there. Hopefully it's out there, but I didn't necessarily see that when I was looking at stuff.
Because I was just looking into calf raises, and calf raises have, I wish I knew how to explain this better, but calf raises have like a normative data for for ages 20 to 29, you're supposed to be able to do a certain amount, like 30 calf raises or something. I don't remember what it is, but
that's interesting. And
then like the number goes down, like 27 for the next range, and then 25 for the next range. And
okay.
I don't quote me on those numbers, but I'm pretty sure like you're supposed to be able to do consecutive amount.
Yeah.
Like,
oh, that's interesting. I didn't know that.
Yeah.
That's good to know. It's interesting that you brought up the normative data, and we'll be able to talk about that later. How that can actually help kind of determine your score on some of these tests. So keep that in mind. So essentially the purpose of these tests, right, these functional tests is, again, the most common that we've said is kind of helping that return to play decision, right? I feel like we've all, I mean, for post-ops, right, there's a lot that goes into that decision, but for some of those more, they're not post-op, but they were kind of long duration injuries, right? You almost kind of get stuck in this like, kind of, I don't want to say guessing game, but you're kind of trying to get a feel of like, okay, are you ready? Are you getting better? Are we progressing correctly? And you know how it goes when you ask an athlete after a while, how you feeling? I'm all right.
Yeah,
I'm good. It's like, okay, like what does that mean, right?
Right. I usually ask them a percentage.
Ooh, that's a good one.
I feel like their percentage is kind of like
dependent on the game that's coming up.
Yeah.
Oh, I'm 100% today.
Like someone was like, oh, I'm like 60. Like, they looked like they were almost back to normal. They're like, I feel 65%. Like, oh, that's so specific.
Did they have conditioning that day and they didn't want to do it?
No, it just funny, like
perception,
right?
Yeah,
right.
So these tests kind of help give another tool to the clinician to determine, okay, is the athlete truly ready for sport, right? If the athlete cannot or the patient can't do this I don't want to say simple, but in general, fairly simple test, well, then they definitely can't play football. Right? So that's kind of the idea behind that. And it's giving you another barometer instead of just relying on, okay, well, where's your pain at? Or it's been 2 weeks, you should be good by now, kind of thing.
So I'm going to play devil's advocate a little bit because I feel like to an extent I agree with like, oh, if you can't like jump off a box and land correctly, then you can't play volleyball or, you know, because you need to jump and land. But also, I guess that's a bad example because that's like pretty functional. But like, there are certain things that you aren't going to necessarily do in sport that I feel like we put a lot of weight on.
True.
Like, when are you going to hop like on one leg?
3 times.
Right.
You know what? And
I mean, it does tell you a lot of information, and I'm not trying to discount that. I'm just trying to talk about the sport-specific aspect of it.
Okay. So let's put a pin in that one because we will talk about that one later. These tests are also a good way to track progress in rehab, right? Especially when you think about post-ops, right? You know, you like to see, are we seeing progress? And sometimes the threshold for the next stage in that long-term rehab is how they performed on a functional test, right? So you're making sure, because these functional tests do have pretty good correlations with strength, right? With like quad strength, like stuff like that, right? So they are a good barometer that, okay, hey, you're still lagging in this kind of performance. Let's start working on that strength component, right? So like if, you know, not everyone has an isokinetic machine to test true strength, right? So this is one way that can help kind of guide, okay, we still need to make this a little bit stronger, right? So it is a good way to track progress in your rehab. And then also, again, as we've kind of talked about, you can use these tests also as an injury risk screening. So you're trying to identify, okay, if someone has a big asymmetry, you know, that could be problematic, right? So that is one area. That's kind of the purposes of these tests.
So I think you know what I'm going to ask you next.
Go for it.
Is this actually useful?
That is a very, very good question. So when we talk about like using these functional tests for return to play, right? The goal, our goal of rehab programs in general is, right, to return the athlete to their pre-injury level, right? We want our athletes to be back to where they were before they got hurt, right? And we also want to take the time to also reduce the risk of getting injured again or possibly injuring something else.
Right.
And this is where functional testing is widely used, right? When anyone thinks about it, a lot of times it's that return to play process, right? So what is the actual evidence behind these functional tests, right? So I have it divided up a little bit into like the lower extremity and then the upper extremity. And the lower extremity, again, like we said it before, most people think of the hop tests. So if you're not familiar with the hop tests, there's the single leg hop, the single leg horizontal hop. So it's just one hop. Then there's the single leg horizontal triple hop. So you're hopping on
for length.
Yeah, you're going for distance, right? See how far you jump. Then there's the single leg crossover hop. So now you're jumping, doing 3 hops, but you're crossing over like the line, like a line in the middle. And then there's the 6 meter single leg hop. So this one's timed. So you go 6 meters and see how fast you can hop on one leg.
The functional test that I'm familiar with that we use at work that one of my coworkers brought in, they're all timed.
Oh, nice. That's cool. Yeah, there's other ones too. There's definitely like, there's some where it's like you're on a single leg, then you like hop and do like a 180. Like you basically spin in the air. That's part of it. Right. There's that one, right? Those are some of like the lesser known ones. And there are some literature on it, but it wasn't necessarily the most predominant one. Again, if you dive into a lot of this research, it's mostly on ACL and those hop tests. And again, they do a battery of it. So they're testing about all 4 of them. When you look at the evidence for these hop tests, especially when it comes to ACL, it's pretty mixed, actually, surprisingly, about how effective these hop tests are at that return to play decision. So there are some studies that have shown that passing all of your hop tests shows a like about a 60% decrease in the risk of injury.
Mm-hmm.
So, I mean, or the risk of re-injury, I should say. So that, I mean, that's fairly big,
That's
but
solid.
but then there's some studies that show like, it's really only small. It's like about 3%, and that wasn't even like statistical significance. So, all right, so it is kind of hit or miss. I think some of the concerning parts to this literature are some studies have even shown that just because you pass the functional test, you still may sustain an ACL tear.
Mm-hmm.
Right? It doesn't necessarily meant you were ready to return back to sport. What I also thought was interesting, there was some studies that have shown that it'll actually increase the risk of tearing the ACL in the contralateral limb.
What will increase the risk?
Passing your functional test. So if you passed, you actually had a higher risk of tearing the other ACL.
I feel like, can they even make that correlation? Like, if you tore your first ACL, then you have a higher risk of tearing the contralateral, regardless of if you pass your functional test or not.
There's part of that. And also, and we'll talk a little more about this, is, when you have an injury, especially when you have surgery, your body changes how it moves. And that also, it affects the non-injured limb as well, especially when you have time off, right? A lot of these people, like, they're not training the same way. So
Right.
Is the other side getting weaker, basically coming back down closer to the other one, and then we're comparing that. Right? So are we truly still ready to return to sport? For the upper extremity, there's really not a lot of great literature out there on functional tests for upper extremity and injury.
I've been thinking about this because I'm trying to think of how I return someone. I feel like it's all sport specific.
Yeah, which is good. Which, I mean, that's what we should strive for, like sport specific movements and stuff. I think most have looked at what's called the closed kinetic chain upper extremity stability test. Essentially, this is you're in a push-up position. Your hands are about 36 inches apart. And basically you're taking one hand, touching the other side, going back to normal, and then using your other hand to touch the other side. And they're counting how many touches within 15 seconds. Yeah. They've also looked at the single arm shot put, which I believe you're just sitting and how far you can throw the ball, basically like shot put the ball. And then there's the Y balance test for the upper extremity, which is similar to the lower extremity one, right? You're on a platform, you're basically moving like a dial as far as you can within a pattern of a Y.
Right, that's what I'm talking about. Like, when are you going to use that? Like,
also, I feel like no one has that. First of all, that thing is not cheap to buy.
no.
Like, you can make it yourself, right? You don't necessarily need fancy equipment. Like, you can literally just use like tape measure and like stuff. But I mean, again, we barely have time to do all the things that we like need to do. Like, making that might be difficult,
Right.
So
that's another thing that we're talking about is with our functional tests. Like, it does take like 20 minutes.
It does. It takes time.
So we really only want to include things that give us valuable information. Like, we're not trying to waste anyone's time, including ours.
Absolutely. And also too, like, you can already tell there's somewhat of a similarity between what we talked about, the closed kinetic chain upper extremity stability test, and the Y balance test, right? Shoulder stability, right? And then now you're just adding a movement to it. Like, are we really testing anything different? That's where a lot of these upper extremity ones have been come into question. Right? So for that closed kinetic chain upper extremity test thing, they use a threshold. And there's some studies that have shown that, a case series that showed the cutoff of 21 touches. So basically being able to touch each side, right? Like, do 21 total touches. If you achieve above that, all the athletes that achieved above that didn't get hurt. And that number was created because that was the one that signified who would get hurt and who would not. So, in athletes that scored less than 21, they had a higher risk of shoulder injuries. Anyone above it had a lower risk. So that's why they used that cutoff. This case series also looked at including strength and fatigue testing, which I think is actually very important because a lot of these tests, you do one motion or 3 movements in the hop testing.
Right.
How many times in sport are we only doing 3 things and, let's call it a game.
Right.
We're done.
And fatigue is where injury happens a lot of the time.
So in that study, did like it was like they did like full can, and then they did some like scapular resistance against like a small percentage of body weight and just counted how many reps they could do. And I can't remember what their threshold became, but the ones that did higher reps were protected against injury, and they were safe to return, and they didn't get hurt in their collegiate career.
This also just has me wondering about baseline testing because, well, baseline testing and is it intra-rater scoring or intra?
Well, inter would be between two clinicians, so if between you and your coworkers.
Okay, so like
Yeah.
rater reliability scoring, whatever the term is. Because with like screening somebody, especially for like a baseline, different people can score different ways, even if you have criteria.
Yeah, that's true.
So I'm just wondering about that.
Yeah,
Like,
I mean, a lot of these tests have scored very well on reliability, like that. Again, inter and intra-rater reliability. So theoretically, they are supposed to be pretty uniform, but that doesn't mean there aren't those minute things that might be different between clinicians. Because remember, when they do reliability studies, it's like only a couple people, and they're calling that the average, right?
Right.
So, but you did bring up a good point with like that kind of like qualitative, like the differences between people, and also the fatigue part, right? And that's all a part of the limitations that these studies have, right? Kind of like what we talked about with like the fatigue aspect, right? These tests are only giving you a quick snapshot, right? We've talked about in a lot of our injury education episodes that strength really isn't a good predictor of injury risk.
What is? I feel like we talk about that a lot.
Exactly. Right. But like, it's really not a strong predictor, right? Yeah, there's some studies that say yes, but then there's some that say no. And it's just not a good indicator, right? Because fatigue could play a big role in that, right? And that's why, doing these tests, it's only like one hop. Like, well, that was great, but what happens in the fourth quarter? Like, do you still have that same level of strength, right? Are you still symmetrical and stuff like that? All right. So that's why I think taking into account that endurance aspect, or even like what you're talking about with the screenings, movement quality, right? Yeah, you jumped really far, but if it looked like poop, is that still beneficial? And that could account for why, like in those studies that did some of the hop tests, why just because you passed didn't mean you were protected from injury. You still ended up tearing your ACL. Right. Maybe they still had poor movement quality, or maybe they had poor endurance.
Well, because I'm wondering with some of these like closed kinetic chain upper extremity things, like how many people are you going to catch with winging scapula?
Exactly, right?
But like who haven't gotten injured yet.
Exactly.
Because I feel like just because they have that after, I mean, maybe that is the reason why they get injured, right? But like just because they have that after and they can't pass.
Yeah.
I think it tells us information.
100%. But to make that the be all, like, oh, okay, you got your 25 touches, you're good to go.
Right.
Are they truly?
Right.
That's kind of the question that it does bring up. Again, like we brought up with like the upper extremity ones, some of these tests kind of just test the same thing in just a different manner. Like all the hops are horizontal. Right. All it is jumping forward.
Okay.
Right. But there was a really good study that looked at a single leg vertical hop, and it was actually identified huge deficits still in even people that passed horizontal testing. Right. So if you don't test that, that's missed. That could, again, explain why someone still may not be ready to return and why they tear their ACL again.
Right. Or that they're just not ready to return and they just stretch their graft and then they're still not functional.
Yeah, exactly. And then, like we said before, most of those upper extremity tests are really kind of just looking at stability, right? A lot of them are like you're just putting your hands on the ground, body weight, doing some movements. I mean, that's not really testing strength or power or fatigue. So that, again, I think these obviously were, don't just they're trash. I'm done with these. I'm never using them.
I think it gives you a good idea of where someone's at.
Exactly. And
how much you can push them.
Exactly. And I think it's a good tool for the clinician to help make a better decision on where we're going with this rehab, and if someone is getting pretty close to play, to return to play, because even what you define as passing can get complicated, right?
Just going back on that topic real quick, like the functional test that we use, I like that it tells me like if we're doing like medial hops, so they stand on one leg and they're hopping toward a medial way, like they are using their abductors, and so that if that is not as fast as the other side, it tells me that they can that we need to work on their abductors.
Yeah.
So kind of like that's where I kind of see where this can come in, where you're talking about giving us a better idea of where that person's at, rather than, I mean, yeah, like it's going to give you information for returning to sport, but I think that we also need to be incorporating sport specific aspects beyond just seeing where the strength is.
Absolutely. But yeah, even determining your passing score is not necessarily 100% uniform, right? Limb symmetry index has 85%, so basically like a 15% deficit, or 90%, 95% have all been examined in the literature.
Well, here's the thing too, is how movement quality.
Yeah.
Because someone can hop really fast and get the same speed as the other side, but if they look like trash doing it.
Also, what kind of compensation to do that? Because that is such a whole body movement.
Landing valgus, or if, what else are they doing?
Exactly. All right. So that kind of comes into question. So again, you as the clinician have to decide what number you're comfortable with. I think most people kind of go around that 90%. So like a 10% deficit is okay. There's some studies that have recommended a formula to look at individual pass rates. So basically you put in certain variables, and I think it was like BMI and like all stuff like that. I can't remember. It was a complex formula. So that just told me no one's practically going to do this. But to find like what that individual number is for each person, I mean, that's an option for sure. And then some people have even advocated using composite scores, so actually making Z-scores. You could baseline an entire team, and there's your group mean, and then you can make a Z-score. But I feel like a lot of that, it sounds cool, but I think practically for a lot of people, that's really hard. That's just the time to do that, and that makes it tough. So again, determining what you feel is what you're comfortable with as a clinician for what you determine as passing is important, and being consistent with that.
And also talking to your doc.
Yes, exactly. Talking to the doc, especially when it comes to that post-op stuff too, like making sure the surgeon's on board with what's going on and what's determined return to play and not. Or what you feel like, hey, I don't think this guy's really ready.
Right.
So we talked about the return to play part, right? That's the big meat of, this functional testing. But now we'll talk a little bit about that injury risk screening. All right. And again, it's kind of looking at mostly these kind of performance tests, the hops and stuff like that. And really the evidence for them to identify injury risk is pretty weak. Some evidence has shown that, hey, maybe the triple hop can show a higher risk of non-contact injuries. So they basically looked at the absolute difference in jump distance. So, the left jumped 12 centimeters less than the right. That's a big problem. So they didn't really look at percentages. So maybe that could be a risk. Some people have found that in the Y balance test for ankle too. Like, hey, you had a difference in how far you pushed compared to one leg. That could be an issue. And same thing with that closed kinetic chain upper extremity test, like we talked about. All right, not being able to do about 21 touches. Hey, you were more likely to injure your shoulder. So I think it just goes back to what we've talked about in the past with like strength. Strength testing has shown, yes, it could. A lot of studies say no. I think it's just a picture. It gives you a snapshot, but it doesn't give you the whole story. So there's more that goes into that. Why are you at risk of injury? And I think a lot of it does go back to training load and fatigue.
And that's something that, like, you're not going to do a functional test for 90 minutes.
Yeah, no, that's not going to happen.
Although we could fatigue them and then do the functional test.
Yep. that has been advocated in the past before for like other exercises to help with endurance. So yeah, that's not a bad idea.
Right. I do like the idea for the injury risk screening. I just think in the traditional setting, most of the time it's a little bit tough to implement.
It is, especially if you're not in a environment that has a lot of hands to help.
I did, when I was a student, have a preceptor who went through an injury screen with our volleyball team.
Oh, that's awesome.
At a community college.
Oh, that's awesome.
Yeah.
Yeah, it's definitely doable for sure, right? It doesn't have to be like, oh, well, I don't work at the University of Oregon, so I'm never going to be able to do those things. No, you still can. It's just you got to get a little more creative with how you do it because there are some limitations, right? Having a staff of like 20 people, yeah, that makes it real nice or like even having a strength and conditioning staff,
right,
can make a big difference because, right, they can help with a lot of this stuff too.
They really can.
And some people don't have exposure to that, like have that available. So yeah, you gotta get creative, but it's definitely doable. You just gotta find what works for you in your setting and what you feel has been successful.
Are we ready for the action item?
I think so. We did remember the action item.
I've been thinking about it this entire episode. So to take away something functional testing that we can act upon today.
Functional testing does have some promise in being able to help you with the return to play process and making you feel better about your decision on whether someone's ready or not. Again, you can't just, we're going to do 3 hops and that's how I'm solely basing, oh, well, you passed all of them, I guess I got to let you go. No, you are still the clinician. All right, this is why you get paid the big bucks, is to be able to critically think and just take that information and extrapolate on that. So functional testing isn't the end-all be-all, but it is an important tool to have in your toolbox.
It is. And my action item is get an idea of what you are interested in whether that's like hops or whether that's like glute strength or if it's quad strength, and kind of just, you could piece together your own functional test. And no one says that there's an end-all be-all way. Yeah. Like if you want to include certain aspects, then go for it. Absolutely.
For sure.
And if you want to include sport-specific stuff too.
Oh, absolutely. And you probably should, right? Again, there's some stuff that has looked at agility. So being able to do certain like the T drill and like all the agility tests, right? Again, I feel like I don't see that very commonly in our side of things.
I use the T drill a lot.
Oh, that's awesome. That's good. But right, I mean, that's fairly sport specific, change of direction, stuff like that. So again, you just, what you have time for, what you have the resources for is perfect, right? As long as you have a system that works, then that's perfect.
So hopefully some of the names of the different tests, you can get a better idea of what you want to look into. And then if you would like to get some references from this episode, you can use Randy's references, which, what were you sitting
Probably rocking around 15
for this episode. So those will be on our website. Again, the CUs, you can go down to the show notes. This is probably going to be, 0.5 CUs probably?
Maybe.
So check the show notes below for CU information. If you guys are interested in listening to stories from athletic trainers, we do every other episode as education or stories. This one was an education episode. So next week we are going back to our stories for our part 2 of last week's episode, where we are talking about what we're looking forward to this year and kind of just in the future of athletic training. If you'd like to submit your story, you can go to Instagram at AT Corner Podcast. And we also have a Facebook group where you can share your thoughts on this episode or post to get other people's thoughts about different topics. And that's facebook.com/group/AT Corner Podcast. And I think that is it.
Yeah, that's perfect. Thank you for helping us showcase athletic training behind the tape. Bye.